Thank you very much to the organizers for your kind invitation to attend this Congress. These are my disclosures. And I am very happy to share with you during the next minutes an update of the current knowledge on the catastrophic antiphospholipid syndrome that, as you know, is the most severe form of the antiphospholipid syndrome that we described together with late Ron Asherson in the early 90s. These are patients having simultaneously or in a few days multiple organ involvement due to multiple thrombosis, usually in the microcirculation, and this leading usually to intensive care units because of organ failure. Although it is really a terrible, terrible situation, it is uncommon. Several years ago, we performed a big epidemiological study in Europe, the Europhospholipid project. We follow 1,000 patients over 10 years. And thanks to this big epidemiological study, we have learned many things on the antiphospholipid syndrome. And one interesting thing is that the catastrophic variant appears in around 1% of patients with this syndrome over 10 years. So terrible, but fortunately uncommon. And in the next few minutes, let's make an overview of the clinical features, the diagnosis and classification, the treatment, and the outcome. And we know most of the things that we are going to talk later thanks to this registry, the CAPS registry. We created this registry in Barcelona, in our center, and the sponsorship of the European Forum on Antiphospholipid Antibodies, a European network devoted to the study of the antiphospholipid antibodies and the antiphospholipid syndrome. And we include in this registry all patients with catastrophic antiphospholipid syndrome that have been published in the medical literature, as well as those cases that are directly reported by the physicians in charge to us. We perform epidemiological studies and statistical analysis from time to time of this registry, and thanks to this we have performed many specific studies of many different aspects of the antiphospholipid syndrome. Currently, we have nearly 1,000 patients with catastrophic antiphospholipid syndrome in this registry. And one of the things, the first thing that we have learned thanks to this registry is that this is a condition of middle-aged people. The mean age of patients in the registry is around 38 years. But it's important also to know that there are children, the youngest is 7 years old, and also elderly people. The oldest is 74 years old. And as the majority of the autoimmune diseases, this is also a condition more frequent in females. 70% of the patients in the registry are females. And it's similarly to the classic antiphospholipid syndrome, a condition that can appear in patients with lupus, associated to lupus, and also to more rarely to other autoimmune diseases such as rheumatoid arthritis, systemic sclerosis, but nearly half of the patients present this variant without any other condition. So they are primary catastrophic antiphospholipid syndrome patients. And it is also very important to know that many patients presented before this catastrophic event other manifestations of the antiphospholipid syndrome: deep venous thrombosis, obstetric manifestation, thrombocytopenia, cerebrovascular accidents, and so on. Around 53% of the patients presented other antiphospholipid syndrome previous manifestations. But you can read this slide just on the other way, is that nearly half of the patients never presented before another manifestation of the antiphospholipid syndrome. So the catastrophic event was the first manifestation of the catastrophic antiphospholipid syndrome. And this event usually appears after some triggering factor, after some precipitating factor. According to the CAPS registry, nearly 2/3 of the patients presented a precipitating factor, being infections the most common. And even just simple infections, urinary tract infections, viral respiratory tract infections, sometimes are also surgical procedures, even minor surgical procedures, such as a dental extraction, for instance, or a kidney biopsy. And sometimes it's a problem of anticoagulation withdrawal or bad control, low INR, or the combination of several of these factors. For instance, anticoagulation withdrawal because of a kidney biopsy. So the combination of kidney biopsy plus the anticoagulation withdrawal can precipitate a catastrophic event. And the clinical manifestations. Well, this is very important to recognize. The number one, the most common clinical manifestation is renal thrombosis, renal microthrombosis. And this is different than in the classic antiphospholipid syndrome, because in the classic antiphospholipid syndrome, the number one is deep venous thrombosis in the legs. And the number two is cerebrovascular accident, stroke. But here in the catastrophic antiphospholipid syndrome, number one is renal, and number two is pulmonary manifestations, pulmonary involvement, and then cerebral, cardiac, and so on. This is a kidney biopsy showing microthrombosis in the glomeruli. It's a classical example of catastrophic antiphospholipid syndrome. Or this is a necropsy of a myocardium, and you can see this microthrombosis in the myocardium. And the lungs, it's number two manifestation. Thanks to the study that we performed with the CAPS registry a few years ago with Silvia Bucciarelli and Gerard Espinosa, we found that nearly 2/3 of the patients, 68% of the patients, presented any kind of pulmonary involvement. But in the classic antiphospholipid syndrome, the typical pulmonary involvement is pulmonary embolism, but this is not the case in catastrophic antiphospholipid syndrome. The number one is acute respiratory distress syndrome, also pulmonary hemorrhage, and the pathological findings are usually thrombotic microangiopathy. And this is an example. This was a pathological specimen of necropsy of a patient who died due to catastrophic antiphospholipid syndrome, and these are the lungs. And these features, pathologists used to call capillaritis, and the term capillaritis looks like inflammation, vasculitis in the lungs, but this is not the case in the catastrophic antiphospholipid syndrome. This is just the way that the lungs react to the ischemia in the microcirculation. This is not inflammation. This is not vasculitis. This is microthrombosis. And the laboratory features, obviously, the main feature is obviously the presence of antiphospholipid antibodies, anticardiolipin antibodies, lupus anticoagulant. But it is also very important to bear in mind that other hematological manifestations are very common and very important. Thrombocytopenia in more than 60% of the patients can appear, and usually it's even more severe than in the classic antiphospholipid syndrome. In the classic antiphospholipid syndrome, it's quite common to find thrombocytopenia or platelet counts around 80,000, 100,000, but in this case are very low, similar to immune thrombocytopenia, for instance. Also, hemolytic anemia, autoimmune hemolytic anemia, is common, 1/3 of the patients, but it's very important that severe hemostatic abnormalities such as disseminated intravascular coagulation or thrombotic microangiopathic hemolytic anemia are also common. In another analysis of the CAPS registry performed with Gerard Espinosa and Ron Asherson, we found that thrombotic microangiopathy features appear in nearly 10% of the patients and disseminated intravascular coagulation in nearly 15% of the patients. And this is just an anecdote. This is the first report on disseminated intravascular coagulation. It was published in 1965 by McKay in Archive of Internal Medicine. And in this paper, they describe a patient with clinical features that they consider are the seminal features of disseminated intravascular coagulation. But if you read this case report, this patient also has a catastrophic antiphospholipid syndrome, having lupus anticoagulant as the antiphospholipid antibody that was at that time the only one that was known. So the anecdote is that the first report of disseminated intravascular coagulation is also probably the first report of catastrophic antiphospholipid syndrome. And let's see the diagnosis and the classification. And these studies were started in nearly 20 years ago, but this working group created at the 10th International Congress on Antiphospholipid Antibodies, we made a big effort to produce a consensus statement on classification criteria and treatment guidelines. You know, the classification criteria included the evidence of thrombosis in 3 or more organs, the development of manifestations simultaneously or in less than a week, and the confirmation of small vessel occlusions in biopsies, and also obviously the presence of antiphospholipid antibodies. If all 4 criteria were present, we call this definite catastrophic antiphospholipid syndrome. If not, probable catastrophic antiphospholipid syndrome. Well, after this consensus, we went to the CAPS registry again, and we performed a validation study. And we confirmed that most of the patients in the registry presented these criteria, and these criteria presented a very high sensitivity, specificity, and positive and negative predictive values. So since then, these are, let's say, the official classification criteria. But at the bedside, we probably need better tools to make maybe the diagnosis, not specifically the classification of the patient. And for this, a few years ago, together with Doru Kerken and Gerard Espinosa, we performed these algorithms that we publish in autoimmunity reviews that certainly can help physicians at the bedside on how to proceed for ruling out other conditions and considering the diagnosis of the catastrophic antiphospholipid syndrome. I really recommend the lecture of this manuscript. And another important issue is that there are many conditions that can mimic the catastrophic antiphospholipid syndrome. So the differential diagnosis is very important with other conditions such as heparin-induced thrombocytopenia, HELP, or thrombotic thrombocytopenic purpura, or disseminated intravascular coagulation. And this topic has already been reviewed by Gerard Espinosa. We, together with Ron Asherson a few years ago, we tried to make a differential diagnosis table. And these were really very difficult because, as you can see, most of these conditions share many of the manifestations. So it's very difficult to make the diagnosis, the differential diagnosis. And this has even more complicated in the COVID times, because even COVID in the severe forms can present a catastrophic antiphospholipid syndrome like thrombotic microangiopathic syndrome. And the treatment. The treatment also, again, thanks to the CAPS registry, we have learned many things. We went also 20 years ago to the CAPS registry, and we checked the treatments that these patients receive. And you can see that the majority of the patients receive, obviously, anticoagulation, steroids, quite common. And then also many patients receive immunosuppressive drugs, some plasma change, some intravenous immunoglobulins. At the time, nearly half of the patients died at the acute event. But those who recovered, the 50% of the patients who recovered, we went to see which were the treatments that they received. Maybe these were the good treatments. And we realized that most of these patients received plasma exchange, anticoagulants, steroids, also intravenous immunoglobulins. And also, if they receive the combination of anticoagulants plus steroids plus plasma exchange or intravenous immunoglobulins, 70% of them managed to survive. So since then, we call this the triple therapy for the catastrophic antiphospholipid syndrome. We always recommend full anticoagulation in order to treat the thrombosis and to prevent new thrombosis. Steroids, and this is different than in the classic antiphospholipid syndrome, steroids, because there is a systemic inflammatory response, and it's important to stop this by means of steroids, intravenous steroids, usually high doses, and then try to remove as soon as possible the antiphospholipid antibodies or the cytokines by means of plasma exchange and intravenous immunoglobulins. So this is the triple therapy. We have suggested this algorithm, and probably the most important is which is the outcome of these patients. And we are very proud to see over the years a decrease in mortality, and we have analyzed which could be the causes of this decrease of mortality in the CAPS registry, and we are very proud that this is mainly due to the introduction of this triple therapy. We have just recently produced this study with Ignacio Rodriguez Pinto, where you can see that those patients who never received the proper therapy have a 75% mortality in the acute event. But if they receive the right triple therapy, the mortality decreases to 28%. So there is nearly a 50%, a 46% decrease in the mortality rate. Or in other words, if you look at the odds ratio, there is 10 times more mortality if you don't use the triple therapy. And these are really robust data. And what happens over the years? Well, the outcome we have seen, also thanks to the CAP registry, that still there are patients that present further antiphospholipid syndrome and even further catastrophic antiphospholipid syndromes over the years. We call this the relapsing catastrophic antiphospholipid syndrome. And these are patients that present with microangiopathic hemolytic anemia, schistocytes. So this is a feature that we'll have to look in these patients with catastrophic antiphospholipid syndrome. And what can we do to these patients that are refractory, those patients that don't respond to the triple therapy or present recurrences of CAPS? Well, many therapies have been tested, but probably the most important are on one side eculizumab, anti-complement therapy that has been reported in some cases with good results. Even a trial was started that unfortunately was discontinued. And recently with Brenda Lopez Benjume and Ignacio, we have, and Ignacio Rodriguez Pinto, we have checked the CAP registry for patients treated with eculizumab. We have found 21, and 2/3 of them managed to survive. And the same for rituximab, another therapy that we usually give to patients who have terrible manifestations, autoimmune diseases due to autoantibodies. And with Horacio Berman, we also checked the CAP registry. We found 20 patients who received rituximab, and again, 2/3 of them managed to survive thanks to rituximab. So you can see that this is a thrombotic storm, and this is also a cytokine storm. So we have to learn more on the cytokines that appear in this catastrophic antiphospholipid syndrome. We know that ferritin, very famous now in the COVID area, is also very high in patients with catastrophic antiphospholipid syndrome. And just to finish, I am very proud that just recently we have performed an evidence-based medicine protocol to assess which is the best way to diagnose and to treat the catastrophic antiphospholipid syndrome, together with the McMaster University. And recently we have produced these Barcelona guidelines thanks to this study, and these have been recently published. And the conclusions are exactly the same that we have found over the years using this data from the CAP registry. And this has been also endorsed by the EULAR recommendations that, that recently have been produced. And this is the work of many people over the years, and we are very proud of the work that we have done. We have published many studies, but mainly we have improved the quality of life of many, many patients. So we have managed to survive many patients thanks to these studies that were performed mainly to the work of many people at the European Forum on Antiphospholipid Antibodies. Thank you very much for your attention.